Tell me something. In 1854, in the Soho district of London, a physician named John Snow plotted cholera death on a map. He noticed that cases clustered around a single water pump on Broad Street. He persuaded the local authorities to remove the pump handle. The outbreak ended. At the time, Snow did not know what caused cholera. The germ theory of disease had not yet been established. He could not have told you that Vibrio cholerae was a bacterium or that it was transmitted through contaminated water. He simply followed the pattern in the data and intervened at the population level. That act, removing a pump handle based on population observation rather than individual treatment, is the founding gesture of modern public health. And embedded within it is the central argument of everything this series covers. Some of the most powerful health interventions do not treat sick individuals. They change the conditions that make populations sick. Before we begin, an important note. This episode is for educational purposes only. It's not a substitute for professional, medical, psychological, or public health advice, diagnosis, or treatment. Content draws from An Introduction to Global Community Health Psychology, published by Routledge in 2026, and from peer-reviewed academic sources. Always consult current guidelines and qualified professionals. If you are experiencing a health concern, please seek qualified professional support. Links are in the description. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS, MBA, MSc, MPH, PhD. Director of the Anaweokhai Institute for Applied Global Health, Udaba-Ekperi, Nigeria. Series 1, Foundations, Episode 5. Today we cover Chapter 1 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Chapter 1, Evolution and Scope of Global Community Health Psychology. Why medicines alone can never fix public health. In this episode, the historical convergence that created this field, from John Snow in 1854 to the Ottawa Charter of 1986, the three great paradigm shifts in how health has been conceptualized. COVID-19 as the field's most important natural experiment, what community health psychologists actually do, and the core competencies that distinguish this field from every adjacent discipline. This is the foundation episode. Everything that follows in this series builds on what Chapter 1 establishes. Let's get to it. For most of the 20th century, two disciplines approached the same problem, human health, from completely different directions, and they rarely spoke to each other. Public health, descending from John Snow, tracked disease patterns at population level. It counted cases, it mapped distributions, it identified risk factors in communities and in environments, and designed interventions that operated at the level of populations rather than individuals. Its tools were epidemiology, biostatistics, policy analysis, and environmental intervention. Health psychology, emerging as a formal discipline in the 1970s, studied how psychological processes influenced physical health outcomes. It asked why people made the health decisions they made, how stress affected physiological systems, how beliefs and behaviors shaped disease risk and recovery. Its tools were psychometrics, experimental psychology, behavior change theory, and individual interventions. Both traditions were generating genuine insights, and both were running into the same wall. Public health interventions that ignore the psychological processes underlying health behavior consistently achieved less sustained impact than their designers anticipated. Health psychology interventions that ignore the social, economic, and environmental context in which individuals were making decisions consistently failed to achieve meaningful population-level change. even when they produce individual level results. The two fields needed each other. Community health psychology is what happens when they finally stopped operating in separate rooms. 3 paradigm shifts that chart how this convergence happened. 3 shifts. Each one expanded the frame. Each one brought us closer to the integrated understanding that community health psychology represents. Paradigm shift 1. From biomedical to biopsychosocial. The biomedical model, which dominated medicine through the mid-20th century, understood health as the absence of biological disease. The body is a machine. Disease is a malfunction. Treatment is repair. Individual psychology and social context are irrelevant to the biological facts. George Engel's 1977 critique of this model, published in Science, was a watershed moment. Engel argued that health phenomena result from dynamic interactions among biological vulnerabilities, psychological factors, and social environmental influences. He called this the biopsychosocial model. This was not a minor refinement, it was a reconceptualization of causation, from linear single-factor explanations towards complex multifactorial systems-oriented thinking. Paradigm shift 2, from the biopsychosocial to socio-ecological. The biopsychosocial model improved on biomedical model enormously, but it still tended to locate the primary action within the individual. It considers social influences, but largely as inputs to individual psychological and biological processes. The socio-ecological model, developed by McLeroy and colleagues in 1988, building on Bronfenbrenner's ecological systems theory, pushed the frame further. It identified 5 interconnected levels of influence on health behavior: intrapersonal factors, interpersonal factors, organizational factors, community factors, and policy factors. The critical insights: reciprocal causation. Individuals influence their environments, and environments influence individuals simultaneously and continuously. You cannot understand individual health behavior without understanding the social ecology in which it occurs. And you cannot change population health outcomes by intervening only at the individual level. Paradigm shift 3, COVID-19 as the field's natural experiment. The COVID-19 pandemic compressed decades of theoretical development into months of empirical evidence. It demonstrated at global scale that effective public health response requires simultaneous sophisticated understanding of population-level epidemiological dynamics and individual psychological processes. That health behaviors are embedded within social, cultural, and economic contexts that vary dramatically across communities. That health disparities reflect complex interactions between individual vulnerabilities and structural inequities requiring coordinated, multi-level approaches. Every country that managed the pandemic effectively did so through approaches that integrated psychological understanding with population-level public health strategy. Every country that struggled did so in part because it treated COVID-19 as either a purely biological problem or a purely individual behavioral problem, rather than what it actually was. Now the evidence, not theory, documented outcomes. North Karelia and Stanford, the evidence. 2 programs, decades of data, the same conclusion. The North Karelia Project, launched in Finland in 1972, targeted cardiovascular disease in a region with some of the world's highest rates. Rather than focusing on individual behavior change or clinical treatment alone, the project worked simultaneously at individual, interpersonal, community, and policy levels, changing dietary patterns, smoking norms, food industry practices, and healthcare protocols across an entire regional population. Over 25 years, cardiovascular mortality in North Karelia fell by more than 70%. The results were ultimately scaled to the entire Finnish population. The Stanford Five-City Project, conducted in California from 1978 to 1992, combined individual health education with community-wide environmental changes and media campaigns across multiple cities. It produced significant reductions in cardiovascular risk factors and demonstrated that multi-level approaches achieved outcomes that exceeded what any single-level intervention could have produced. These are not theoretical claims, they are replicated empirical findings. Multi-level interventions consistently outperform single-level interventions. The evidence has been available for over 40 years. The question is not whether the integrated approach works, it is why it has taken so long to become the standard. What precisely does the practitioner who emerges from this field actually do? If you are watching this as someone trying to figure out what this field even is, this slide is for you. The practitioner who emerges from training in community health psychology has a distinctive profile. They are not clinical psychologists focused on therapeutic relationships with individual clients. They are not epidemiologists focused on disease surveillance and population statistics. They are practitioners who can move fluidly between both domains and who understand that the most important action is often at the intersection. Their competencies include understanding individual psychological processes underlying health behavior change, familiarity with population thinking, including epidemiological concepts, system thinking that conceptualizes individual behavior as embedded within social context, requiring coordinated change across multiple influence levels. Their practice settings are equally varied. Academic research, bridging individual and population analysis, community organizations developing culturally adapted interventions, government agencies translating research into policy, international health organizations designing scaled behavior change programs, clinical settings where structural determinants matter as much as biological ones. The unifying characteristic is this: wherever a community health psychologist works, they are asking the same questions. Not just what is wrong with this person, and not just what is wrong with this population, but what is the relationship between this individual's experience and the social, cultural, economic, and environmental systems within which they are embedded, and where in that system is intervention most likely to produce lasting change? The competencies that make that question answerable. 5 competencies. Every practitioner in this field needs all of them. 1. Understanding of both individual psychological processes and population health determinants. 2. Familiarity with psychological and epidemiological methodologies, the tools of both traditions. 3. Cultural competence and community engagement skills, the ability to enter a community as a partner, not an expert. 4. Multi-level intervention design capabilities, designing programs that operate simultaneously at individual, interpersonal, community, and policy levels. 5. A commitment to health equity as a core value, not a peripheral concern, requiring theoretical frameworks and intervention approaches that address both individual factors contributing to disparity and structural factors maintaining inequities across populations. This is not a narrow technical skill set. It is an orientation towards health, a way of saying that holds individuals and populations, psychological and social, in continuous productive tension. John Snow removed a pump handle in 1854. He did not know the germ theory. He did not have molecular epidemiology, or randomized control trials, or behavioral economics. He had systematic observation, a commitment to following the evidence wherever it led, and the willingness to act at the population level rather than waiting for a case-by-case clinical solution. That spirit, the willingness to look at the full system rather than only the individual, is what this field inherits and extends. 19 episodes, 19 chapters, everything from risk perception to climate change, from infectious disease to artificial intelligence, from cultural adaptation to the future of the profession. You are at the beginning of the course. What follows is the curriculum. This episode is based on Chapter 1 of An Introduction to Global Community Health Psychology, published by Routledge in March 2026. Chapter 1 is the foundation on which every subsequent chapter builds. If this series is your entry point into global community health psychology, the textbook is the next step. It's available on Amazon.com and from the Routledge.com website. Links in the description. Episode 6 covers Chapter 2, Core Theoretical Frameworks. 7 theories that explain why people make the health choices they make, their strengths, their cultural limitations, and how to combine them. If this episode has been useful to you, here's how to go deeper. Subscribe to this channel at Anaweokhai Institute on YouTube for the complete books to video library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers. Link in the description. The Practitioner's Course in Global Community Health Psychology is available on Gumroad. 8 weeks. Everything this textbook covers, built for practice. Link in the description. And the textbook itself, An Introduction to Global Community Health Psychology, is available from Routledge and on Amazon with multiple payment cards and platforms. Everything begins there. Health is not destiny. It's been Dr. Anthony Iyore Anaweokhai. I'll see you on the next one.